This presentation was developed by Group 19 for Class 450 for Cal State San Marcos. California's 2016 End-of-Life Option Act. Group members are Reina Chupina, Shadi Begui, Denise Johnson, Norwin Holchester, Melissa Lodge, Haley Rico, Jacqueline Rowland, and Venquin Zhu. Thesis. California's 2016 End-of-Life Option Act is a component of end-of-life care that enforces the ultimate choice of a dying person's right to self-determination. Definitions: self-determination. Self-determination is the freedom to make decisions without being influenced by anyone else. Self-determination theory, developed by Dacey and Ryan, highlights the physiological process that promotes optimal functioning and health. This theory focuses on three basic innate physiological needs that are the basis for optimal functioning and personal well-being: competence, relatedness, and autonomy. California's End-of-Life Option Act allows each person the ability to autonomously make their own decisions. This act allows a person the liberty to decide when they want to stop suffering. Right to die. What is meant by the statement right to die, in reality, is the right a patient has to refuse unwanted treatment. When a person is mentally competent, one of the fundamental ethical principles is respecting patient autonomy. Autonomy is supporting and facilitating the capable patient's exercise of self-determination in healthcare decision-making. A key point is that a person exercising his or her right of autonomy must be mentally competent. To be able to be autonomous, a patient must be able to fully comprehend diagnosis, prognosis, and treatment options, be able to weigh benefits versus risks, be able to make a decision, and be able to communicate his or her decision.
Okay, good, do it again. Hello, my name is Norwin Holscher. I am doing a presentation on how the peaceful end-of-life theory supports the California end-of-life care option. The peaceful end-of-life care theory by Cornelia Rowland and Shirley Moore is a mid-range theory that's based on Donovan conceptual framework. It is composed of three parts, in which the first part is the structured setting, which includes the terminally ill and their support persons. The second part is the process, which includes nursing interventions to reach the desired outcomes. And the third part would be the outcomes. Positive outcomes, as based on the peaceful end-of-life theory, could include comfort, dignity, and respect that can be achieved by supporting rest, contentment, privacy, and allowing the patient or their family to make decisions to achieve the desired outcomes. And feeling at peace can be promoted by encouraging familial emotional support and closeness throughout the dying process. The California End-of-Life Care Option Act allows a terminally ill individual to request a prescription drug that he or she can self-administer to end his or her life from a participating physician. The law can provide an option for the terminally ill to experience a painless death with dignity, comfort, and respect as possible positive outcomes identified in Rowland and Moore's peaceful end-of-life theory. A common fear among the dying remains the loss of control over bodily functions. The end-of-life care provides a terminally ill person to end his or her life with dignity, respect, and privacy without undergoing the immobility and incontinence associated with a significant decrease in physical and mental loss of normal function. not to mention the psychological pain of knowing that his or her family must carry the burden of handling his or her basic hygienic needs. A study by Kill in 2006 has identified being in control as one of the attributes of a good bed. With the end of life care option, the terminally ill is able to make the ultimate decision to die before becoming a burden to his or her own family. Thank
Hello, my name is Shari Patel. I am one of the students of and I'm going to present my portion with California 2025 Option Act. So in this presentation, I'm going to talk about challenges which are facing this California 2016 Deadline Act. So basically, there are three most challenges facing to this act. One of them is religions and spirituality. The second one is ethics, and the third one is laws and social media. The first one is religions and spirituality. Death or dignity laws allows a terminal ill patient to hasten an inevitable and unavoidable death. While many faith traditionals adhere to ancient traditional and understandings of physical life's final journey, modern medical technology has opened the door for faith leaders to actively reconsider some beliefs. The most challenging issues facing the act of end of the life in California is interfering with God's destiny and decision and is immoral. If suicidal is immoral, then it must violate some duty to God or oneself, according to Epistle 2016. The philosopher goes to the detail and said, we don't have such duty. I think our normal human activity involves imposing our own mental purposes on the physical world, such as when we decide to alter the flow of the river for irrigation, and this is perfectly in accordance to the God's providence. Suicidal, according to this, is just another instance of altering the physical world, our bodies, especially for our own purposes. Also, if determining the time of death is entirely up to God, then it would also be wrong to lengthen our lives, such as through medicine, surgeries, and use all technologies to improve and learn our life. The other challenges are ethical issues. All human beings are mortals, and hence death is an inevitable occurrence. Advancement in medical technology are changing the norms of nature here, and this could be an ethical issue for people who are opposing this law, according to Sonora 2016. Some may argue that suicidal is permissible as a matter of freedom, so long as it does not violate the rights of others, it is ethical. As Dr. Sonora explains, autonomy and having the freedom to getting decisions is part of ethics. I think one of the big challenges related to ethical issues is lack of knowledge of patients towards their disease and make the right decision. In this regard, healthcare professionals can play an important role to providing detailed information about an advanced medical treatment which can be used during end of the life care. I believe torture and pain is another subject which should be considered related to ethics. It's not ethical any human being to suffer and going through extreme pain when there is no cure for the certain diseases. The other challenges are legal and social challenges. Since the law is new in California, all the possible legal and social ramifications present daily through exercising the law. According to the National Nonprofit Compassion and Choice, since June 9, 2016, at least 504 terminally ill adults in California have received prescription for the lethal drugs. But the group does not know how many of them actually ingested the drug, according to the Federline 2017. The cost of the drug was around $3,500 per prescription for combination of the sedative and drug that stops the heart. But there is not proof that how much of the drug is used to stop the heart and what will happen to the rest of the drug. I think this issue would be less challenging if the medical treatment members monitor patients more regularly and assess and evaluate patients' situation and evaluate how much more drug patient needs to satisfy their needs, their wishes to die with dignity. Therefore, the rest of the drug could take back to the pharmacy and less challenging of the drug abuse for the people who access to the medication prescribed only for someone to die with dignity. Hypocratic oath doesn't just say that doctors shouldn't harm patients, but specifically providing poison to kill someone, according to the Wonder 2017.
Death with Dignity became talked about in the media with the introduction of Brittany Maynard, who's a 29-year-old female who was diagnosed with terminal brain cancer, and it was incurable. I believe it was a famous case for the media because she was a young, beautiful newlywed who was choosing to end her life with dignity on a day of her choosing. It was shocking to people who felt she was so young and strong and that she could fight. Amidst the controversial feelings surrounding her decision, she moved to Oregon, stating she wished California had these options. In her final days, she advocated for change in policy, writing that the treatment options would have destroyed the time I had left. In a video message from Brittany that could be found on her website, thebrittanymaynardfund.org, as well as interviews with Brittany, she talks about what points led to her decision. She had tried treatment and surgery already, but despite the effort, the tumors continued to grow and invade her brain. Further treatment would burn her scalp, and throughout the process, she could deal with mood and personality changes. She did not want to lose herself or her dignity, and did not want for her family to see it either. So once she established residency in Oregon, she got her prescription. She explains the immense amount of relief she had upon getting the prescription, and held on to it for 3 weeks before her chosen time and situation of her death, in her home surrounded by her closest family. It happened on her terms, and that gave her and her family peace of mind. And in one of her last notes, she writes, "Goodbye to all my dear friends and family that I love. Today is the day I have chosen to pass away with dignity in the face of my terminal illness. This terrible brain cancer has taken so much from me, but would have taken so much more." And at the bottom of the screen, you see her quote, "I'm choosing to suffer less, to put myself and my family through less pain." By utilizing death with dignity, the disease process and expectations are talked about early and realistically, giving families and patients all the information and options possible to figure out what best fits them. So this is important in our talk in nursing of the importance of patient and family-centered care. It's important not only to provide patient with the best possible care, but also to assist the family through the palliative phase and into bereavement. Quality of the last phase of life and the quality of death can affect psychological and physical health of family caregivers. Patients aware of their upcoming death may present with fears. If the fear is family-focused, it may help give them peace of mind knowing that their family will see them pass peacefully with dignity and no suffering, giving the family members a better chance for decreased anxiety, depression, and complicated grief. If the fear is control-focused and the concern of not knowing exactly when things could turn for the worse, they could find peace knowing that they have medicine to control how and when they want to pass, and also knowing that once they have the medicine, they don't ever need to use it if they decide it's not for them. Just having that control for many patients is powerful. Lastly, if the fear is pain-based, they can rest assured knowing that they have the option to pass before the pain gets unbearable. Having the option is not only beneficial for the patient, but also may help the family if the patient chooses this route, because watching someone you love suffer and then die would be traumatizing. Death with dignity gives loved ones a chance to prepare. Research suggests that unpreparedness can increase and extend the bereavement process while increasing the risk of depression, anxiety, and complicated grief of family members. And speaking back with Brittany Maynard, one of her notes before her passing, because she was advocating for death with dignity before her passing, says, "Because the rest of my body is young and healthy, I am likely to physically hang on for a long time, even though cancer is eating my mind. I probably would have suffered in hospice care for weeks or even months, and my family would have had to watch that. I did not want this nightmare scenario for my family, so I started researching death with dignity."
Process for applying End-of-Life Option Act. The eligible patient and his or her attending physician must follow several steps, such as the patient must take 2 oral requests, at least 15 days apart, directly to his or her physician. The patient must also make 1 request in writing with 2 witnesses and provide it directly to his or her attending physician. The patient must discuss the aid in dying drug request with his or her attending physician without anyone else present to make sure the request is voluntary. The patient must then see a second physician who can confirm the patient's diagnosis, prognosis, and ability to make medical decisions. If either physician thinks the patient's ability to make medical decisions could be impaired, the patient must also see a mental health specialist, psychiatrist, or licensed psychologist to make sure his or her judgment is not impaired.
Hello, my name is Denise, and this is my portion of our End-of-Life Option Act presentation. So healthcare providers should voluntarily participate. However, at times, the hospitals, based off of their being religious, will not allow the physicians to participate in the act. They can recommend that the patient see their primary care doctor for additional resources for the aid in dying drug. However, they themselves cannot prescribe it. And it says here as well that physicians are allowed to opt out of the End-of-Life Act. They're also protected by the immunity from liability. Immunity from liability. And what this means is that the act provides that healthcare providers that participate in actions taken in compliance with the act will not be subject to civil, criminal, administrative, disciplinary, employment, or any contractual liability or staff action, sanction, penalty, or liability in connection with the healthcare provider's participation in actions authorized by the act. This is pretty much saying that they won't be held accountable if the patient actually takes the drug. Some physicians agree with the law because it does help to open up that platform for further discussions, such as pain management and other end-of-life care issues. Let's see here. As far as nursing goes, the nursing implications, there was nothing specifically listed for the End-of-Life Option Act of California. However, there were many generalized end-of-life care implications and interventions for like palliative care and hospice nurses. Because we are at the bedside, it is okay for us to discuss these concerns with the family. Pain management being one of them, the family's depression or the patient's depression about the diagnosis, fears, self-image, personal values, cultural values. As nurses, we are trained to be culturally competent. So providing this type of care is very holistic to the patient and makes them feel a little bit more comfortable. Also helping patients with setting up meetings with financial people. One concern of theirs is usually the financial end, like their trust and things like that. The other thing is possibly set up a meeting with spiritual advisor or with a priest, etc. California statistics a year later after the law was implicated. So I didn't find anything for 2016 to 2017 or 2017 to 2018 by the CDPH, which is the California Department, of Public Health. There was nothing listed. However, there was some information about the act for 2016 after it was activated. So after the enactment, there was 191 individuals who were actually prescribed the medication and only 111 who actually ingested the drug. 21 people did not take the drug and were reported to be deceased due to their subsequent diagnosis, and 59 individuals were undetermined to have either taken the drug or passed away before the report was completed. According to the statistics, the majority of the patients who ingested this drug were patients that were 60 years of age or older, Caucasian, with a college degree, who had some sort of malignant neoplasm. And this concludes my portion of the presentation.
Hi, my name is Jacqueline Rowland, and I am part of the group that is presenting on California's 2016 End-of-Life Option Act. I will be presenting on the interview portion of this project. This project and this topic is especially intriguing to me because I am an oncology nurse. I see patients and physicians deal with life and death situations on a daily basis. Who is going to be interviewed? ND, an oncology physician in Santa Barbara. Oncology physicians frequently deal with the dying process in the different stages of chronic diseases. Once the law was passed, there were some physicians that were open to the change and some that were not. And this particular physician was open to the change. I believe that interviews with experienced individuals are often the best way to acquire real information, things that they have seen and are applicable to real life. The hospitals around where the physician worked did not fully endorse this new change. The hospital where I work, in fact, does not endorse the new change. However, the physicians that are affiliated with being inside and outside of the hospital are able to make their own decision on how they go about this change. Below are the questions that I asked the interviewee. Why are we open to the possibility of assisted suicide? The answer was, I see many patients with uncontrollable pain at the end of life, and many stated that they wish they could take that pain away from themselves as well as their families. Second question, have you had patients ask you to order medications for assisted suicide? The answer was yes. Someone that I had been working with for quite some time and had been with them throughout their progression of their disease for many years. What did your patient say about why they wanted to go through with this? The answer to that was, the patient had fought a long battle, and when it was known that despite all interventions, the disease had progressed, they made it clear that this would prevent any further suffering. Do you see other physicians not wanting to be involved? There are a few that feel uncomfortable with assisted suicide. To that, I responded, I can imagine that after so many years of thinking and working on ways to continue someone's life that it would be hard to change the mindset from prolonging or continuing the life to letting the patient have the choice to end it. The physician responded, yes. As an oncology physician evoking hope in patients, do you find it particularly hard to be involved in assisted suicide? The answer was yes and no. It is very difficult, but it also helps knowing that the patient has some control over themselves despite their illness and its progression. At the conclusion of this interview, I felt a deeper understanding for why some patients might want to use this assisted suicide. I see patients on a daily basis with reoccurring admissions to the hospital through the emergency department for pain and symptom management. A lot of them, it seems, might want to end their fight with this terrible battle of cancer and have dying with dignity be an option for them as well as their families. Thank you for listening.
Hello everyone, I'm Haley and I'll be going over the pros and cons of the End of Life Option Act for the state of California. So I'm going to start with the pros. Some of the pros include reduced pain and suffering. The diseases that lead to a terminal diagnosis, including cancer and ALS, are often result in severe debilitating pain. By choosing an aid in dying allows the patient control over how much pain and suffering they can tolerate. Another pro is patients can die with dignity. Towards the end of life, we often lose the ability to control bodily functions such as bowel and bladder. This task then falls on the caregiver, whether that be a healthcare professional or a family member. By choosing an aid in dying allows the patient to die with dignity and without humility. Another pro is reduced healthcare costs. Did you know that in 2011, Medicare spending reached close to $554 billion, which amounted to 21% of the total spent on U.S. healthcare in that year? Of that $554 billion, Medicare spent 28%, or about $170 billion, on patients' last 6 months of life. So you have to remember that insurance only pays a portion of the bill. That leaves the rest of the bill and the burden up to the estate, oftentimes family members, loved ones. Another pro is it allows family and loved ones to say final goodbyes. Knowing when you're going to die and choosing to die allows you to prepare and say goodbye on your terms. Maybe that means making amends with people that you haven't been on good terms with, etc. It also allows the patient to feel a sense of control over the inevitable. We have no control over cancer or ALS or other diseases, but this puts the control back into the patient's hand. It allows them to control whatever little control they have left or of a situation and circumstance that they don't have control over anymore. It also allows for a calm, peaceful, controlled setting. This allows them to choose the environment by which they want to pass, surrounded by those they want to be surrounded by. Maybe they want special music playing. Maybe they want special pictures around. Maybe they want special people around. Some of the cons include physician participation is voluntary. So participation in the End of Life Option Act is voluntary for individual patients, health providers, like physicians, nurses, pharmacists, etc., as well as health systems such as HMOs, hospitals, medical offices, nursing homes, pharmacies, and hospices. Insurance providers are not required to cover aid in dying drugs or related physician fees, according to the Coalition for Compassionate Care of California. It also goes against the doctor's Hippocratic oath to first do no harm. Another con is that it demeans the value of life and makes life seem insignificant. Another con is there's stigma involved with it. So it's considered by many to be physician-assisted suicide versus physician aid in dying. It's how it's phrased out. It depends on whether it's positively framed, like the life of the patient should not be prolonged or passive euthanization, versus negative framing, the life of the patient should be ended, or physician-assisted suicide. It also goes against religious beliefs, with 13% of California hospitals being religious-based and 20% of home health agencies being religious-based. It limits the number of available resources. I'm now going to go over the proposed action item that we came up with. Our proposed action item was a brochure to hand out to interested parties. I'm not going to read through this entire brochure as we've covered all this information throughout this presentation. I am, however, going to go over what's included in the brochure. In this brochure, it was important to note the background of the law and include in it the eligibility criteria, the requesting process, and the alternatives. Before making such a big, literally life-changing decision, we need to ensure that the patient is aware of all the alternative options, including hospice and pain management. Oftentimes, patients are afraid of the pain, or they're in so much pain and suffering. We need them to know that we can manage that pain, that there are other options. It's imperative that the patient knows that they may withdraw at any time. Regardless whether the medication has been obtained or not, they may withdraw. They do not need to continue on. We would start by administering this resource because it is a sensitive subject and because the patient needs to request from their physician on 2 different occasions, 15 days apart. The medication, we are going to start with providing this to physicians, nurses, hospice administrators, etc., those people who deal with patients who might be interested in this. So there's a palliative conference in April. That would be a place to start to provide to these administrators and people who work with palliative care, so that it's a resource and a tool that they can use when the patient expresses interest. This concludes my portion of the presentation.
These were the references used to develop our presentation. Thank you for your time, and I hope you enjoyed the presentation.